Hello, and welcome to another episode of Cardiometabolic Beat, brought to you by the Cardiometabolic Health Congress. Today, we have the pleasure of speaking with Dr. Stanford, Associate Professor of Medicine and Pediatrics, as well as Equity Director at Massachusetts General Hospital Endocrine Division. Dr. Stanford is a leading expert in the treatment of obesity and has done a significant amount of research about the racial and ethnic disparities in obesity management, which will be our topic of conversation today. Thank you so much for joining us today, Dr. Stanford. I'd like to start by asking you, there are a lot of myths, stigma, and misunderstandings about obesity in general. How are these issues compounded in minority patients with obesity?
So absolutely, when we look at weight bias and stigma, it's important to recognize just the two most common forms of bias here in the United States, which are race bias and weight bias. So you can imagine the overlap of the two leads to worsened outcomes in communities of color that unfortunately are having to deal with both. We know that weight bias is pervasive, is often an accepted form of discrimination. And we know that unfortunately, particularly with the recent murders of George Floyd, Ahmaud Arbery, Breonna Taylor, that we have paid special attention to racism and its impact on health and health outcomes. So when we're looking at individuals that struggle with obesity, those from minority communities disproportionately have worsened outcomes as it relates to cardiometabolic health, cancers, depression, anxiety, and a host of other diseases, which is secondary to the overlap of both race and weight bias.
What are some of the highlights of how obesity impacts individuals from ethnic and racial minority groups? Are these disparities pronounced both in prevalence and adverse obesity-related outcomes?
Absolutely. So what we do know is that there's a much higher prevalence of obesity in communities of color. I'm going to speak through the lens of being a Black woman, physician, scientist, and this is what really brought me to the work. So if we want to just look at kind of the numbers, let's capture them. What we do know is that 42.4% of US adults have the disease of obesity based upon 2018 data from the National Health and Nutrition Examination Survey. I specifically emphasize 2018 data because the data is not yet available for 2022, but we can anticipate that there has been some advances and a much higher prevalence of obesity as we've gone through the COVID-19 pandemic. When we look at the prevalence of, let's say, overweight and obesity in Black women, I'm going to focus on this cohort because that's the cohort that I belong to. We know that about 60% of Black women have the disease of obesity and about 20% have overweight, which means that 80% of Black women have overweight and obesity. I think we can agree that those numbers are quite high. And with that comes a host of chronic diseases. Unfortunately, we know that obesity causes over 200 chronic diseases. And if we have a higher degree of obesity, which is often the causative factor of those diseases, these disease processes are often more pronounced in communities of color, leading to not only greater morbidity, but also greater and earlier mortality.
Wow, I had no idea. And certainly some of our audience, I'm sure, hadn't had that idea either. Thank you for sharing.
Yeah.
In your experience, what have been some of the most challenging aspects in managing obesity and long-term weight maintenance in patients from racial and ethnic minorities?
I think the key thing in both racial and ethnic minority populations and those from majority populations is the lack of recognition of obesity as a disease. People see obesity as a lifestyle choice. And if people just eat less and exercise more, then they should be the weight they want to be. And with that, have no other obesity-related diseases. But what we do know is that obesity is a disease. It is a disease characterized by how the body reacts to storage of what we call adipose or fat tissue. What I would say, if we don't recognize that obesity is a disease, you can imagine that treatment strategies and or seeking treatment for obesity tends to happen less in communities of color. People don't know that there are people like me that exist, obesity medicine physicians whose sole purpose is to treat individuals with overweight and obesity. If you don't know that we exist, then you're probably not getting access to treatment modalities that are based on evidence, like, the use of pharmacotherapy and or, medications to treat obesity or metabolic and bariatric surgery. And we do know that disparities in both medication utilization and bariatric surgery happen in the racial and ethnic minority populations in the US, where there is lesser access to those in communities that are minoritized. So it plays out significantly in the work that I do. I think a lot of my racial and ethnic minority patients that do seek me because they hear me on, I would say the lay press. They may hear me on CNN or MSNBC, or they may see me in the New York Times or whatever it might be. And that piques their interest. Wait a minute, there's a woman that looks like me that's doing this work. How can I get in to see her? How can I ensure that my family is cared for by her? But obviously, I can't take care of the entire country. My goal is for there to be others that come from racial and ethnic minority populations to proliferate. And indeed, I have helped found the Council of Black Obesity Physicians, where if people are looking for persons that are racially concordant, as we know that data shows that racial concordance in terms of care, particularly in the Black population, leads to better outcomes, then they have a potential source for individuals by which they can receive care. I know there's a long and complicated answer, but I think it speaks to the complexity of what we see as it relates to the lesser access to care for those that come from communities of color here in the US as it relates to weight and weight management.
Oh, okay. Well, we know that you are the leading expert in the treatment of obesity. What made you choose this path, and how did you get to where you are today?
That's a really great question. I can tell you that I've known that I wanted to go into medicine since I was 3. I'm now in my 40s, so that was a few years ago, we're going to say. I had no idea that there was a field like obesity medicine. And I would say, as one of the first fellowship trained physicians in the field, there wasn't really this field to look to when I was in medical school, for example. There were people that were involved in bariatric care, meaning the care of just those individuals that undergone bariatric surgery. But when I was doing my master's in public health over 20 years ago, a lot of the projects that I worked on in the School of Public Health at Emory in Atlanta, my hometown, were specifically surrounding addressing overweight and obesity within the Black community in the Atlanta, Georgia area. I worked with a gentleman by the name of Dr. Ken Resnicow, who is now a professor at the University of Michigan, on several projects that were focused in the Black community. One was called Healthy Body, Healthy Spirit. It was a large experiment, technically, that was being led in Black churches, where we would randomize churches to intervention versus not, and provide materials on healthy eating, exercise, these types of things. There was another project I was involved in called Go Girls, which focused on addressing overweight and obesity in Black adolescent girls within the Atlanta area. And so that definitely set me up for trying to discern why is there the disparity we see in terms of the larger prevalence of obesity within the Black community, and how can we use culturally appropriate tools to make some interventions, and then getting into deeper level knowledge of understanding the genetics and other reasons why we may see these disparities. This is part of that brought me to the work. And as someone who advocates across the spectrum, regardless of race or ethnicity, being known as one of the experts does help me to have a voice and hopefully change the narrative with regards to obesity as a disease, and helping people to recognize that this disease is not their fault.
Wow, that's quite an interesting journey. You wanted to be a doctor since you were 3. I mean, that's a long time. And look at all you've done. A long time,
yeah. And now I have 5 degrees, so it's
that's amazing.
Yeah,
it really is.
Yeah.
So what are some clinical pearls that you can share with our audience about how they can take better care of themselves and, avoid obesity and everything you just talked about?
Yeah, I think I'm going to shift your question a little bit here, because I recognize that almost half of our country has the disease of obesity. So I want to focus on what can we do as we approach weight and weight management. I would say number 1, recognize that obesity is a disease. Number 2, recognize that while we do want to utilize lifestyle and behavioral therapy, which include looking at our diet quality, physical activity, stress, sleep, etc., if we've maximized those things and we still are struggling with our weight, it might be time to seek care from a physician like myself, someone that actually focuses on the treatment of this disease. if and then that does arise and you do seek care, recognize that there are tools that are being underutilized for the treatment of obesity, which include medications. For the treatment of obesity, we know only about 1% to 2% of persons that meet criteria for medications for the treatment of obesity in the US actually are prescribed such medications. Similarly, we see the same with bariatric surgery. Less than 2% of individuals that meet criteria for surgery get access. And we know that this is the disparity is there when we're talking about racial and ethnic minority populations. But if these modalities of therapy, i.e. medication or device or surgery, are deemed appropriate, be open-minded and receptive to these being tools as one of many tools that can be utilized to help someone address their weight. And I would say be positive and don't beat yourself up if you do happen to struggle with excess weight. There are those of us that are out here that can help you get to the happiest, healthiest weight for you.
So what would you recommend? First, going to your primary care doctor and then going from there and then seeking out maybe a test and then seeing a specialist like yourself?
Yeah, so I think, it depends on, what your strategy is. Some people aren't well established in a primary care setting. I think having a primary care physician is the way to go. But if, let's say, you don't, and you know that you've been trying to do appropriate lifestyle changes without any success, then you would go and find an obesity medicine physician in your area. The easiest way to do that is go to abom.org, which is the American Board of Obesity Medicine. And on that site, you can actually search to find a physician in your city and state without any type of paywall. So you can just go and look that up and find if there's someone in your area that you could see as it relates to your weight. And those will be only the people that are board certified in obesity medicine in the United States. And I think that's an easy way to navigate if you do indeed struggle with your weight and are wondering how you can achieve maybe better results than you've had on your own.
Thank you. That's so helpful. Is there anything else you would like to share with our audience? Any other tips or advice you have today?
Yeah, I think that the key thing, and this is going back to that bias piece, is number one, don't judge yourself or others. And I say don't judge yourself because I find that my patients with obesity tend to be highly critical of themselves. And this level of criticism often leads to really poor outcomes. And so allow someone like me to help you be your best self. Similarly, I would say don't hyper-focus on any particular number. A lot of people use things like BMI targets, but BMI targets are not founded in science. They're actually based upon metropolitan life insurance tables from the 1930s and 40s, which didn't include, for example, racial and minority populations. So having a target number based upon the 30s of only white individuals might not be the most sound thing to do. I think we have to recognize that there is a different weight probably that everyone needs, and that we have to recognize that, there's not a one size fits all approach. And so be cognizant of that and recognize the heterogeneity of who we are as humans and embrace that. And I think that if we do those things, then we'll have better outcomes, better mental health surrounding our weight and weight status, and are able to achieve better sustainable outcomes.
Thank you very much, Dr. Stanford. It's a pleasure, and thank you again for your time and expertise. Also, thanks to all of you for listening. If you have any questions at all, or if you have any feedback on topics that you would like us to discuss in future episodes, we would love to hear from you. You can email us at info@cardiometabolichealth.org or through social media via Facebook at Cardiometabolic Health, or via Twitter and Instagram at CMHC_CME. Thank you, and until next time, have a wonderful day.